Well, thank you, Eric. Thank you very much.
Thank you.
Terrific. Well, thanks so much. And if you feel comfortable, please don't be afraid of the front row. I know it's always challenging, but we're always like to be warm and friendly here at the NATO Association. My name is Robert Baines. I'm the President and CEO of the NATO Association of Canada. It's an organization dedicated to informing Canadians about the values, security, and the importance of NATO. Most people don't think about that on a day-to-day basis. That's wonderful. We're not expecting that people should always be appreciating security 24 hours a day, 7 days a week, but it is one of those correctives. It is one of those thorns in the brain. We need to make sure Canadians every once in a while are reminded that this doesn't happen by accident. Our peace and security has taken decades of work, and a lot of that is through multilateral integration like NATO. So much effort, so much collaboration, non-zero sum alliances are what have really helped to power Canada's integration into the world and has really made our impact leveraged, 1,000-fold essentially by working with our allies. So I'm glad that all of you are here and that all of you are part of our NATO community. Please continue to, every time you see one of our events, think about attending or sending to your friends. And please do let everybody know it is the 75th anniversary of NATO, and these are the kinds of things that we need to celebrate. In the media, you will always see another atrocity, another problem that's happening. Well, there are a lot of good things that have happened as well, such as our fine institutions that we have developed over so many years after so much effort, so much pain, so much suffering. We really do need to celebrate those kinds of things. So most NATO countries have some form of independence anniversary this year, and it's a wonderful thing to celebrate those kinds of peaceful celebrations of our flourishing. So it's really important that we all recognize that now more than ever, because if that's not something that makes a nice quick Instagram reel or TikTok story. It's something that we have to keep mentioning to each other. So without further ado, I'd like to introduce one of our team members at the NATO Association, Apostolos Zezos. He's been our events coordinator for the past 5 months, I guess, and Apostolos helped to make tonight possible. Apostolos.
Thank you, Robert, and good evening to all of our attendees. I'm Apostolos, your event coordinator for the day. On behalf of the NATO Association, we welcome you to our conversation with Dr. Andrew Beckett, titled Revolution of Trauma Care, Lessons Learned from the Battlefield. The NATO Association of Canada is a non-for-profit, non-governmental organization that promotes the values of peace, prosperity, security, and the importance of NATO to all Canadians of all ages from coast to coast. Today, as we gather to discuss an important topic in Canadian security affairs, we celebrate the 75th anniversary of NATO, which is coming up on April 4th, 2024. Make sure to stay up to date with the NATO Association of Canada to not miss out on upcoming celebration opportunities. Dr. Beckett practices general surgery at St. Michael's Hospital, where he's the director of trauma care. Dr. Beckett has spent nearly 2 decades in the Canadian Forces, where she serves as a lieutenant colonel in the Royal Canadian Military Medical Service, having served multiple military missions overseas. He holds active positions in the Canadian Armed Forces, including Chief of General Surgery, Trauma Advisor to the Surgeons, General and a Senior Advisor on the Canadian Forces Health Services Blood Program. Dr. Andrew Beckett has also been a leading researcher in his field of massive transfusion and has greatly contributed as an associate professor at the University of Toronto to the study of freeze-dried plasma as part of Unity Health Toronto. We're honored to have Dr. Andrew Beckett with us today, and we're eager to learn more about his contributions to the revolution of trauma care. Please join me in welcoming Dr. Andrew Beckett.
Thanks so much to the association for inviting me to speak tonight, and thanks to all of you that are interested in this topic and have taken the time out of your busy schedules to come. And I think this talk is, I'll rely on the usual Chatham House rules from the RCMI to discuss, and some hard truths about the, what we're facing and where we're at. And so I hope it's going to be thought-provoking and promote some discussion. I think, in my journey through this, I think you'll probably find some things that you'll realize that there's a lot of work still to be done in terms of trauma care within the military setting. So again, the standard disclosures, and so the revolution in trauma care it's slightly disappointing, and I think most of you will find. So we have peacetime trauma care. A conflict starts, and the medical services are not ready. And it takes time to upskill people and get people trained and sort of mobilize the healthcare resources of a country to respond to the need. And then we start off at high fatality rates. In the first couple years, we'll see sustained high fatality rates. And then it gets better because we learn lessons and we train people, and things get better. And then those innovations start filtering out into the civilian world, and the conflict ends. And so then the civilian side, they will start looking at the innovations and try to start trialing them on civilian populations. And gradually the things that work in the civilian setting that come from the last conflict are gradually adopted, and then the cycle repeats itself. So it's a very, discouraging process, and I'll talk about some of the reasons why I think that is. And it's not just Canada, but it's all across all of NATO that we're all in the same position. And one thing, I remember this quote in this from a guy called Siccardelli in the U.S. military, and he said, "If your son or daughter is wounded in the next war, you better hope it's in year 3 or 4, you're not year 1 or 2. Because the medical services and physicians and nurses will think they're ready, but they're not." And so I think that's kind of true throughout every conflict that we've seen. And I've seen a few settings, and that's me from the 1990s, and it's hard to remember when I had black hair, but that's how it was. So I've seen a few iterations of this, and it's true. We learn lessons from these previous experiences, and then we forgot them, and then relearn them again painfully on the backs of people dying, and so that cycle just repeats itself. And one thing to understand is that this A.J. Walker from the Royal Navy had this paper is during peacetime, okay, the militaries get cut. And where can you save a lot of money? Well, you can cut health services. You can cut that. So we should close hospitals. We don't need them. It's too expensive. We can let medical people go. We don't need them. They can go work on the civilian side. We don't need them. We can get if something happens, we can always get them back in. And then the cuts just keep happening to a point where, leadership has to make a decision. What do I want to cut? Do I want to cut my tanks, or do I want to cut my field hospitals and ambulances? And so, I don't want to cut my ships, so let's cut medical again. So this cycle, repeats itself to the point where, you don't have really a capable medical organization. And of course, physicians and other people, we're doctors and nurses and other professions, and so we're interested in other things too. So we don't get invited to the tables because we're off doing other things, seeing patients and other priorities, and so we're not included at the tables when some of these decisions are being made. So this is called the Walker dip, and you see this cycle happens. The first couple of years of the war, your performance is very low, and it starts going up, and then you reach a peak, and then the war starts winding down, and then capabilities drop, and then you go back to this the bottom of the curve. And I would say Canada is. I don't see if I can get my pointer there. I don't know if you can see that, but I'd say Canada, as long as most military native countries, we're about the bottom here somewhere of what our capabilities are, and to meet a large scale number of casualties. And I think it's not to denigrate any of our very dedicated medical providers and health services, but they can't do it alone, right? Your whole system needs to be mobilized and ready to do it. And, and I think it's what every NATO nation is functioning is like, even on the US side, their capabilities are very low too right now, and they're very concerned about this. So we bottom out every time, and then we have to start. But what's really important to know is, as the further you go down that curve, the more lives you're going to lose. So if you're starting from the bottom and you have to climb up, while you're climbing up, there's going to be a lot of unnecessary death. As people learn, they relearn the lessons from past conflicts, and it takes time. And there was a good, and I'll talk about this guy later, his name is Edward Churchill, and he wrote a book called Surgeon to Soldiers about his experience as the consultant surgeon in the Mediterranean during the Second World War. And he said it's like, war surgery and combat casualty care, it's like a specialized practice. And he said it would be like at the end of one day you come to the hospital and say, we're stopping neurosurgery, we're stopping brain surgery, lock the doors, we're done. We're not going to do this anymore. And then 20 years later, you come and take the lock off and go, hey, we're going to do brain surgery again. And so you have to start out from the bottom again. And all the people that knew the lessons, and after the war, they didn't really write them down, they weren't passed on, so you're starting afresh again every time. And let's face it, this is a young person's game, and all that experience is gone every 20 years. And so it repeats itself time and time again. And who pays the price is our casualties. They pay the price with unnecessary complications, unnecessary deaths, with all the suffering that entails. So that is the cycle that we go through. And lesson learned, well, I would propose that we actually don't even really learn the lessons, because we say we do, we write them down, and we still cut. We still don't resource these assets appropriately. And, I would say that, it's really not learned. And I think, in the political leadership, the hope is we're never going to have to do this again. We're never fighting a war again. It's not going to happen again. So why spend all this money on hospitals? And so how many, military hospital beds do we have in this country for inpatient care? What's that?
It's going to be depressing, isn't it?
Zero.
Right.
Zero. So we have no hospital beds. If there was a surge of casualties, nothing. And, and how many, military patients could the civilian system absorb?
Zero. Now it's terrible.
Well, we could, but we'd be canceling surgeries, and we'd be canceling bypass surgery, we'd be canceling chemotherapy, we'd be canceling all this stuff. So, this is the situation that we've got ourselves in, because it was never going to happen again. We didn't need that excess capacity. We didn't need it. And you can imagine the difficulty with policymakers now. They're left holding the bag, and it's if we get into a war and we start sending patients back that need ICU care, and the civilian, now we have to negotiate with the provinces to get patients into the provincial systems, and how is that going to work? And so this is just me speculating, but those are difficult, conversations to have. So, the lessons learned, and particularly the Vietnam War, and this really started the modern trauma care experience in the United States. By people saw with the advent of rotary wing medical activation, extraction of casualties, and to rapidly bring them off the battlefield into surgical care facilities. This was kind of revolutionary, and it was seen to improve the quality of care, and things were better for patients. And this was brought back from Vietnam to the American civilian system, and they saw, and this is really what the modern standard trauma care, really started. And by the way, in Canada, having helicopters and blood on helicopters, we have a province in Canada that doesn't even have helicopters for trauma care. So if you're going skiing on Mount Tremblant and you get in an accident or something like that, you better be ready to drive back to the border of Ontario because there's no helicopter coming to get you in Quebec. There are no helicopters. So, so we haven't even really embraced that, despite this being in the States for like over 50 years now. And the other thing is they did all this stuff in Vietnam, but still when we went to war in Afghanistan and Iraq, is the U.S. military didn't really have a unified trauma system. It was all designated to commanders and what they thought was best, but they didn't really have an organized trauma system. So the U.S. military had grown separate from what was happening in the trauma systems of the American civilian side. And so basically what they did when they were planning, they eventually said, we need a trauma system. We're seeing too much excess mortality. Is basically what they did is they took the map of Texas with its trauma system plan and helicopters and where all the hospitals were, and they laid that template down over Afghanistan because it's roughly the same size, and that's how they built their trauma system. It was built on Texas, what they did in Texas for optimal patient care, and so that's what they did. So again, you have this cycle of lessons failed to be learned, not keeping up with what's happening in the civilian side, and basically, it'd be nice to say, in the military we do everything right all the time, and then the civilians learn from us, and then we get better every time. But once the conflict ends and we lose all that experience and the lessons are lost, and then we're back to square one. Again, and this is what Edward Churchill said is, you always start at the beginning again, which is really discouraging. Let's face it, is even myself, I'm one of the surgeons that was in Afghanistan, and there's just getting few and far between the number of people that actually served as a surgeon in Afghanistan that are still actually in the regular force. And so you always have to go through this long learning period. And who pays the price? The patients pay the price. Unnecessary complications, death, and we learn this time and time again. And you think it's, kind of, because actually the human matter hasn't changed, that the matter that we're consistent of, whether, I was shot in 1945 or in 2027, the human response to injury is still going to be the same. It hasn't changed in 40,000 years. You're still going to bleed the same. The tissue reaction is going to be the same. You're going to get infected, all these things. That has not changed. Yes, weapons are more effective, but the human substrate in response to injury, it doesn't change. That's fixed. And we're fixed with that process. And I think everybody wishes it was different, but it's still the same as it was 40,000 years ago. So, the Americans have lamented that this is just history repeating itself. And I was talking to my U.S. colleagues a few weeks ago, and again, they're facing budget cuts too, like everybody is. And they have the U.S. Armed Services Blood Program, so they're one of the few countries that has its own blood program, and they're able to manufacture and distribute products and supply their own forces as they see fit. But the U.S. military is actually looking at cutting the whole program to save money, because we can say, we can buy it off the Red Cross. We don't need our own independent system. So again, we're not the only country that goes through this cycle. It's every NATO country faces this, because where are you going to cut? Are you going to cut that ship, or are you going to cut the medical services? And I understand why those decisions are made, but if there's a problem, there's going to be a bill to be paid, and it's going to be paid in death. And then, I know a lot of people, they say, well, I just hope I'm not around holding the bag when that bill comes due. So, this is a world where, a good lesson learned. This is Monty. The Americans actually showed them this picture. They go, who's that? Like, oh, wait, he didn't really do anything. We did everything. So Montgomery in his memoirs of the 1939 to 1945 war, he said, generals must not only win battles, they must win it with a minimum of casualties and loss of life. And you have to do that as a leader. Now, those of you that were remembering the Afghanistan conflict for Canada, you remember every time there was a body that was repatriated, a casualty that was repatriated, and the flag was at half-mast, if that flag is staying down for months on end, because every day, that becomes a political risk. And for commanders, if you're having unacceptably high casualties right now, especially in current climates, how long are you going to be in charge for? So those are real risks that mount up for leadership and politicians now, and this is me speculating. And so what he said was, and this is Montgomery, writing in late 1940s, blood transfusion, surgical teams working well forward, air evacuation, direct to a base hospital, thus saving bumpy journeys by road, nursing sisters working well forward in the battle area. And this is the 1940s, and we still can't do this well. And it's true, this is what we've been trying to do for the last, since I've been on the blood program the last 10 years or something. So, and we still can't get this right. And we still can't convince stakeholders that this is important. And we still can't convince them that by not tackling these problems now, there's going to be a bill to be paid. So, and maybe people think, well, I'm going to be retired, then it's not going to be my problem. But that bill is being made up for somebody coming down the line, and somebody's going to be holding that check, and it may not be pretty. So what is NATO now facing? And that goes to your question, what's the importance of all this? Some history buffs will notice the picture on the right. There's an Adrian helmet being worn by French troops, as well as a gas mask. In the picture on the left, where do you think that's from?
From Ukraine.
That's from around Bakhmut. This is an artillery war. And the Ukrainians are, for every one shell the Ukrainians are firing, the Russians are firing 5 to 10 back. And that ratio is only going to get worse the way things are going. We are fighting an artillery war, with our allies in Ukraine. So, and can we support them with the artillery they need to maneuver and to defend properly and to evacuate casualties? So this is a quote from David Petraeus that some of you may remember. He had a quote that's like, the conflict in Ukraine is now like All Quiet on the Western Front meets Blade Runner. So you have this technological stalemate, just like in the First World War was an even match of machine guns and barbed wire versus artillery, where, and the artillery turned up the ground so you couldn't advance. So you have this stalemate because anytime you get any assembly of troops, a drone spots you and then they can target artillery, so you're stuck. And that bears well for casualty evacuation too, because the Russians have figured out if you kill the medics, that's like killing 5 Ukrainians. You kill one medic, that kills 5 Ukrainians. And I had a candid discussion with the Ukrainian Surgeon General, the former Surgeon General, General Oshchenko, and she said, we were talking about how long the medics should be trained for, and their medic training is, pretty short. It's like 6 weeks or something like that. And people said, well, it should be longer, should more skills, and they said it's pointless because they're dead in 8 weeks. We can't afford to give them longer training because they're dead in 8 weeks. It's not worth it. And again, it's the targeting of vehicles by drones, ambulances by drones, and the number of medical treatment facilities being hit is, this is now serious business for health services of people. So I want to talk about a little bit of a case. There's no medical presentation that's complete without a case study and to get people's interest, but this one will be interesting to you, I think, and it's going to get me out of trouble with any kind of military authorities because this is nothing about operational security. So, this is a picture on the left-hand side of a young man, about 20, 21 years of age. His name was Revere Osler. And he was the only son of the gentleman on the right called Sir William Osler. And he was well known at the most famous physician in the world. At this time, he was the Professor Emeritus, some big professor in Oxford anyways. And Professor Regis at Oxford in medicine. And so one of the most famous physicians in the world. And so his only son, Osler, Revere, who was the great-grandson of Paul Revere, hence the name, he was a young man. He was not very interested in studying in medicine. He liked playing tennis and fishing and reading poetry and things like this. He wasn't, what his parents wanted him to be really, but he felt that, he should do something for the war effort, so he dropped out of, college, and he joined a nice, safe, cushy base job at No. 3 Canadian General Hospital, which was the McGill Hospital, because it was secured by Osler's connections. So it's nice, he's the quartermaster for this unit. And so he's a somewhat, gangly-looking young man. But that kind of changed, and as the war progressed on, he was getting a bit tired of base life and felt like he should do some more. So he transferred to the Royal Field Artillery in the British Army. So this is a picture of Osler on his leave of the summer of 1917, when he was 21. And so he then returned back overseas to Belgium, where there was the Third Battle of Passchendaele was occurring. And this, again, was a large-scale artillery battle where the Commonwealth casualties were about 300,000. The German were about 250,000. And this occurred from July to November. And with the village of Passchendaele being finally captured by the Canadian Corps in, I think it was mid-November, with a lot of, like over 17,000 casualties. So during the course of this fighting, there was an evacuation chain set up, and the evacuation was actually a pretty slick system, because now this is 3 years into the war, where evacuations could be done within about 7 hours from the front line of an artillery war. 4 hours to 7 hours to evacuate a casualty, which seems like a long time compared to Kandahar, when it's like, oh no, they got to be on the operating table in an hour. They have to be in an hour. And this is the scale of fighting an artillery war with stretcher bearer transport, ambulance transfer, and then eventually to rail transfer. So this is how it would go in the Battle of Passchendaele. So on August 29th, 1917, a German 4.2-inch shell landed, where Osler and some colleagues were standing in a shell hole. Multiple were wounded. So medics came up, stretcher bearers came up and dressed the wounds. And it's often said in medicine, the person that applies the first dressing sets the course of the patient. So there's no more important dressing applied than the first one in terms of treating a casualty. So dressings were applied, and he was brought by stretcher to an advanced dressing station of number 131 Field Ambulance located at Canadian Farm. And then he was transferred via road ambulance to Essex Farm, to number 47 Casualty Clearing Station. So by ambulance via Essex Farm to number 47 Casualty Clearing Station at Dosingham. And Essex Farm may be familiar to you because that's where the John McCrae bunkers and memorials are located at Essex Farm Cemetery. And so he got there at 1900. So, pretty rapid evacuation for that time. So again, this is just remind you, this is about, usual time is about 4 hours. So if you do this drive on a Google map, it's about a 20-minute drive. It's not very far, but you're dealing with roads under direct observation, under shell fire, etc. It's really, and do you know how you know where all these casualty clearing stations were and all these advanced dressing stations were? Do you know how you know? Because the cemeteries are there. If you want to find where the dressing stations were and the casualty clearing stations, that's where all the cemeteries are located. And how you know it was most likely a casualty clearing station or a medical station versus just bodies recovered? Because most of them will have names, they were identified. So they were identifiable enough to get evacuated back because somebody took the time to get their name and details. So that's how most of these areas, you won't see a lot of, unknown soldier type graves. It will be, most of them will have a name, and that's how you look, you can identify them, which is, you can see there is like Essex Farm Cemetery, Canadian Farm Cemetery, Dosingham Military Cemetery. And that's how you know. So this is where the story gets really interesting. So just another Commonwealth soldier being evacuated to a casualty clearing station, hoping to survive, most likely going to die. So they realized the importance of Revere Osler, and because of his father, they sent out a telegraph to Harvey Cushing. Harvey Cushing was probably the best known brain surgeon in the world. And he was working at Mendingham this is before the Americans were in the war, number 46 casualty clearing station as part of the American medical provision. And they said, can you come? So in the pouring rain, because as those of you that are history buffs, they know the whole Battle of Passchendaele turned into a quagmire of misery, of shell holes filled with dead mules, dead men, and slime because of the rain. So he proceeded over to number 47 casualty clearing station in the pouring rain. So in his notes from his journal, from the book he published after the war, is it could not have been much worse. So one fragment was traversing the upper fragment, because remember, this is an artillery war. These are fragmentation rounds. Another penetrating the upper chest just above the heart. Two others in the thigh, fortunately without a fracture. He also summoned his friend, a world-leading expert in blood transfusion, to come help him. George Cryle. He brought his blood transfusion set to do a fresh whole blood transfusion. So they got over there and they were able to transfuse some blood. And this is from Remy Station, which is also a military cemetery, big one. And they brought in all the top specialists because this is William Osler's son. And they found lots of clot in the abdomen, and they were able to start an operation on him. But in the end, he was unsalvageable. And this kid probably got the best care possible at the time. And I would say, could we do this now? Give somebody a fresh whole blood transfusion? Well, we've trained people, we say we can do it. Could we actually do it in these type of circumstances, not in special forces, but on conventional side military? Could that even be possible? So he was buried in this cemetery, and I was actually at the cemetery in September. I was out in Ypres Salient in September, and so it's a kind of a soggy place, and this is his grave today. So over 100 years on, and this is the son of the most famous physician in the world at the time, still well regarded. There's many, auditoriums named after him. And if you look carefully at the grave, there's no epitaph. It's Revere Osler, age 21. And if you go through these cemeteries, you go row after row of people in their 20s, early 30s, in their teens sometimes. And this is what an artillery war produces. And the Canadian military and coalition forces were very good at dealing 1 and 2 casualties, severely injured casualties. But what if we had 100 a day? 200 a day? And this is what an artillery war produces. So this is from August in the Ukraine, an estimate from the New York Times of 500,000 casualties on both sides. This is before the Ukrainian offensive really got going. I would say it could be possibly around 1 million on both sides now, possibly. And the injury pattern is exactly the same. These multiple body areas, so the big orange one, I didn't really project well here, but this is multiple areas, and this is the type of injury. These are fragmentation injuries in orange. This is data from the Ukrainian Surgeon General. So this is an artillery war. It's the same thing that happened to Osler's son. It's the same thing that's happening every day in the Ukraine. Multiple wounds, the most common form. And that produces this. So, interestingly, in the Ukraine, so in Afghanistan and Iraq, most of the casualties were brought to, the trauma centers or the combat support hospitals or Roll 3s by helicopter. Look at in Ukraine now, 1.9% by helicopter. 34% by road, and by rail, 63.7%. 63.7%. And you can see in the picture in the upper left there, that's at a railhead, ambulances lined up waiting for an ambulance convoy to come in. And what happened in the First World War? Ambulance convoys by rail. Because if you're going to send a whole medical team to extract one casualty, that's very inefficient. Even to move people by ambulance, 2 or 3 medics per vehicle, oh, that's a lot. When you can put 2 or 3 medics on a whole rail car of 20 patients, 30 patients, way more efficient. So in a well-developed rail system, that tells you something. And that's the scale we're facing in the Ukraine. And if things don't go well there, this is what NATO could be facing, evacuating people by rail. And how many, rail ambulances does Canada have?
Probably zero.
How many road ambulances do we have that work? I don't know. So, so the scale of the Russians' losses are, it's enormous. I mean, I think anybody looks at the news and just I think yesterday I saw some report that they lost, over 1,000 casualties in one day, and they lost, 300 armored vehicles. So, I mean, the scale is enormous. And those type of numbers are very disturbing because what the Ukrainians find is, well, the Russians don't look after their casualties. This is not a problem for them. And who has to wind up looking after them if they're captured? It's the Ukrainians. And what would happen in a conflict with NATO with a lot of Russian patients requiring care, where would they go? Well, the capturing nation is responsible for their care. So just like in World War II, where there were big German POW camps in Canada around Dundurn and near Gravenhurst and New Brunswick, you wind up being responsible for their medical care. So imagine that drain on our human healthcare resources. So, and this is the point why I'm telling you this story about Osler, is a lot of patients in the Ukraine, they just die in transport coming back. They die en route because it takes hours. It's no better than it was in Passchendaele. No better. Sometimes worse. Sometimes worse. And can you imagine probably just like in World War I, is ambulances, they get the person back, but they're already dead. Because they just bled to death slowly over hours. And this is the conditions that we're facing. So, and we know what we have to do. Monty said it. You need blood transfusion, surgical teams, aeromedical evacuation back to base hospitals, which may not be possible, with modern air defenses. And you need good nursing care. But can we do that on a scale? So in World War II, around about 50% of Canadian human healthcare resources were deployed overseas. 50%. So imagine if we went to your hospital and said, look, we want to send your patients back here, and we want about 50% of your doctors and nurses to deploy. Can you imagine having that conversation at a provincial level? That would be some very tough decisions that you'd be in an unenviable place. And then, the civilian side, well, what can you guys do for us? Well, we can give you some training, I guess. And that would be the answer. So, who knows what the actual toll on, Ukrainian casualties is. I mean, they're very closely to their chest, and I'm very respectful that this is just misery on families and grief. And it impressed on me this last time I went is in Ypres Salient is you read the epitaphs, and I'm sure many of you have seen them, is like, the epitaphs on the tombstones, and they often say, thy will be done. And some of the more poignant ones say, one day we'll understand. So another big, huge challenge for NATO is if we ever got into a conflict, and I know there's very good work being done by the Ukrainian community to support some of these people. This surge of amputees, and this is from the summer, 20,000 young people with amputations, 20,000. That's the biggest number since World War I. And we had a delegation with the Ukrainian Surgeon General here, and we went to our civilian colleagues. They wanted us what's the best in amputation care, and it was completely not transferable experience here. Do you know who gets amputated in Canada? Who gets amputations? Diabetics and people with peripheral vascular disease. It's not young trauma patients. Very few trauma patients get their limb amputated. We don't even have the experience to deal with this. And those of you that you've seen those Canadian World War I art books. And there's a picture from the Davisville Orthopedic Hospital, and it's called Shrapnel Corner or Whiz-Bang Quarter, in fragments from France. And it's a picture of it's a painting of all the Canadian military amputees sitting on that corner hanging out. And that's where they hang out. And how would we cope with that again? We've lost all that. So obviously, Zaluzhny, it's unclear to me whether he's still in a position or if he's leaving. He is?
Yes.
Yes, I've been watching, but I haven't. I've just been following. There seems to be some turmoil. But I think obviously he's a very smart guy, and I think he remarks that they'll need some kind of technological breakthrough to break through this, and they'll need a lot of Western support. And in my opinion, and this is my opinion only, is that he's probably a bit of a realizing the mobilization of more people to actually go into this. And obviously it's a very unpopular thing to conscript and mobilize people. But not, I shudder to think if we have to do that here. Even mobilizing healthcare resources. How would we mobilize healthcare resources? How would we do it? And one of the big challenges in healthcare right now is, one is the Canadian healthcare system was never designed to weather a pandemic. Never designed. Because that happened in the 1920s, right? So in 1918, the Spanish flu. We never have to do that again. So we set it up for, peace care, peacetime care. And it was never set up to weather a major global conflict. It was never set up for that. And so Canadian healthcare right now, and those of you in healthcare, it's like, it's not the same it was pre-pandemic, and it's shaky. But if we ever had to go back to Canadian healthcare workers and say, hey, we're all in this together. Remember the last time, a couple of years ago? We want you to come back, and this is going to be mandatory overtime and mandatory deployments to cover these redeployments to, nope, you're going to be back in the ICU covering. A lot of people would just say, no thanks. And would we force those people to go to work because we needed to? And I think there's one thing, those of you in the Canadian community, I'm sure were tracking this, but I read a report from CNN that the women under the age of 60 with healthcare training are now conscriptable, so they're not allowed to leave the country.
That's not true.
That's not true? Okay, that was...
It's just a compromisation of bragging. Basically, they're trying to create, from political field, they're trying to create a society what chipping to each other, fighting between each other, so they could increase the corruption in the higher level government cabinets.
Well, fair enough. I think, it raised a concern on my thing, just looking at to Canada, that what would we do if we had Canadian healthcare workers that wouldn't work or tried to leave the country?
Full-scale invasion usually helps to realize the...
Yeah, but what would we do here if we had to mobilize healthcare
You'd
assets?
wait a year and then you'd conscript.
Well, yeah, I mean...
We are sharing the same border over Arctics.
Yeah,
How many Canadian army personnel here in the Arctics? 1 for 10,000 kilometers, square kilometers. 1 person. Yes, taking care of polar bears.
So, I think...
By the way, oh, sorry.
Yeah, and I was just going to say, I've met with Ukrainians at various conferences, and so I have tremendous respect for what they've been able to do in, I mean, I'm sure they were in that walk or dip too. They had to rapidly expand, get people out there, and Ukraine is a 40 million-ish country, the same as Canada, and we would really struggle too. So these are issues that come to mind on what we would do. And I think the medics and things, keeping to the thing, the person who applies the first dressing really going to determine the outcome of that patient is really important, and especially when you're trying to generate large-scale numbers of qualified people, and they see things like, because they've had to mobilize people and get them as medics, and of course there's problems. And one of the big scandals that's come up is the tourniquet issues, and not only there was some corruption issues that were alleged, and I don't know all the details of that, but for sure I know that there were problems with training in tourniquets, because if you leave a tourniquet on for too long, for over 6 hours, well, that leg is coming off. Even if it didn't need to be on, that leg is dead, it's coming off. And so the post-tourniquet syndrome has been a real problem for Ukrainians, and because it was okay with U.S. and Western type coalition forces in Afghanistan, Iraq, because we can get somebody to a hospital within an hour and we can sort it out. But if it's 6 hours and the tourniquet's on, well, that leg is coming off. And so this has been an issue as well. And another thing that's coming back is trench foot. Last winter, there was a lot of reports of young Ukrainian soldiers who are hunkered down in their trenches under a shell fire, with standing like knee deep in water, and limbs being amputated from trench foot. And that's a big loss of manpower when you're losing people, amputations because of trench foot. And we thought we had beat that problem. Never going to happen again. Well, human physiology hasn't changed in 40,000 years, and it's going to keep happening. So the other issue I think is really important to understand is the targeting of medical treatment facilities. And this is new. This is not something we've had to think about in like 80 years. And the targeting of MTFs, deliberate targeting of MTFs. Lots of reports of that. I think I read somewhere, and you can correct me if I'm wrong, but it was about 10% of Ukrainian health facilities have been targeted. And sometimes with loss of life. I know from the blood transfusion community is that in Kherson, they were, not Kherson, in Dnipro, they were making a call for blood transfusions, and people lined up and to donate blood, and then it was targeted. It was destruction of the facility and donors. So, so this is something, in the First World War we did see this. One of the first nursing casualty of what was her name was, I can't remember, his name's Margaret something, or no, Catherine MacDonald. She was from London, Ontario. No, she's from Brampton. And she was working at one of the Canadian hospitals, and the Germans came over and bombed the the hospital and she was killed, and she's buried in one of these big military cemeteries. So that's something we're going to have to face up. Again, in Afghanistan, Iraq, it would be something very random, but these would be deliberate targeting of medical treatment facilities. So, meaning like, well, how do we position our IMTFs? In NATO, do we have to dig them all underground? These are hard questions. Our Chief of Defense Staff says that we have much rapidly switch gears in an increasing chaotic world. I personally tend to agree with him. He said that industry has to get on a war footing, and that means biomedical industry has to get on a war footing too, in terms of blood production, in terms of the R&D for countermeasures, new types of blood products, blood storage devices, different types of surgical equipment. So it's not just the industry making bombs, bullets, and beams, it's other things, including like, what's the best tourniquet? We need to have better blood packaging systems. We need to have what's the best medical system. And we also have to get our healthcare training pipeline expedited to produce practitioners in the event of a crisis. So it's not just the arms industry that has to get on a war footing, it's also the healthcare industry has to as well. Because what's the first cry in battle? It's follow me. What's the second cry? Medic. And as Tim Hodgetts, the outgoing chief of COMEDS, said is commanders always have to plan for casualties. If your plan is a good one, there'll be the enemy's casualties. If the plan is a bad one, there'll be your casualties. So you always have to plan for casualties. So, somebody asked me, Andrew, like, well, these are all expensive things and hospitals and it's annoying. And isn't there any other thing that we could invest in that is cheaper and makes us streamlined? I said, yeah, there is one thing we could do. We could buy a lot of little wooden crosses because there's no other way around these things. Blood products, surgery, good nursing care, transport, because that's what it is. And of course, people don't like that answer. So just a couple of points from the NATO blood panel. So for one of our medical treatment facilities, we would need, for about 10 operations a day, we would need 96 units of whole blood equivalent for 24 hours. In the first week of any major NATO conflagration, the low end of the estimate would be 10,000 units of whole blood equivalent in the first week, just for military casualties. Where would we get that product on top of normal civilian demands? It's all hypothetical. So, when I tell these numbers to logisticians, they're like, oh, this is like too much, we can't do this. Well, these are big numbers, but this is for every casualty that requires a blood transfusion, you need about 8 units of red cells, 8 units of whole blood equivalent, about 8 units. And it's not us making the numbers up, that's what history, because to come up with these numbers, the NATO blood panel is, we went back to Korea, Vietnam, World War II, and Normandy campaigns, and the needs are like tremendous for blood products. So, this is going to add up very quickly for us, and there's not a good plan to do it. And where do we get most of our blood products from in Canada? Well, there's one blood authority. And could we, you guys hear on the radio every weekend, we need blood, whatever. Well, could we scale up? How fast would we be able to scale up to meet the needs of this and the regular needs of civilians and keep the show on the road in hospitals? How many people would line up and donate? And even more importantly, where would we get the blood bags from and all the tubing? And where does that stuff come from? That comes from the Indo-Pacific region. So if you have 100 casualties, which would be reasonable in an area of operations. You know, and this is how much product that would look like coming in the door every 24 hours, and hopefully into patients. So, anyways, we've been trying to make these things interoperable, but you know, it's with our European colleagues, you know, regulatory issues, import-export regulations, and all this stuff. It makes it very difficult to actually standardize the use of blood products across NATO. We try. You know, we're hoping that if something really happens, some of this regulatory business will fall away. You know, so at least we can get product into some people. And we may have to accept that, you know, unfortunately, you know, having a hepatitis C infection is a problem of the living. And like, because our transfusion safety, you know, it's obviously the more production, like we're so focused on safety in the Canadian transfusion community, but if you're trying to stop people bleeding to death, like there may be some trade-offs with safety, and that's a very contentious issue. And just to reiterate what the work we do at NATO, we have to convince commanders that this is a complicated thing. It's not just like, hey, we could just order up 20 units of all this blood products that's sitting on a shelf anywhere. It's perishable. It only lasts a maximum of 40 days. So it's just like, you know, like finding oil. You got to go find it. So you have to go find donors. You got to transport it somewhere. You got to refine it, produce it. You got to then package it and ship it overseas and then put it into a tank. And that's the exact same thing that you have to do from getting it from a donor vein into the vein of a recipient. Like it takes all these steps. So it's just not something that you know you can spool up. But luckily, is the having a supportive public is the blood is walking around in everybody. You know, we can get that product out of people if they line up. But unless we do it all in Canada, we don't have blood security. If we rely on Americans or Europeans to do this, we have no security of that product. It's just like relying on oil from the Middle East. We don't have security over that product. We don't have strategic security of that project. And so this is some more of the other stuff. So, you know, logistics. This is all about logistics, like any good military operation. And it's complicated because of cold chain. But, you know, we can do that. So dried plasma. That is one of the things that I, as I mentioned, I work on a lot, is because this is the only product that you can freeze dry it, and it's good in a room temperature for like 2 years. So you can stockpile the product. You can put it in every soldier's backpack and send them out there. You don't have to worry about it, and this is why you can get some blood into somebody that's better than, you know, just saline. So, you know, despite everybody, including the U.S., working on this project, you know, we have not really increased any domestic dried plasma production. And it's mostly because we just don't have enough money. You know, $1 million here, $1 million there. Yes, we can make little chunks step forward, but to really nationalize the program, we have to, you know, tens of $millions to make this work. And this is the only contingency product that we're going to have. And right now, they did randomized controlled trials, all this medical stuff. It works. It saves lives. You know, and we were able to secure some of the new Octapharma product that's made in Europe, but it's like the Hunger Games. It's like COVID vaccines. It's like we were negotiating with it, $500 a unit, and the Americans came in for one ship. We'll pay $2,000 a unit. Okay, like you're negotiating to the highest bidder with these type of programs. So we are trying to work it on ourselves and get some security, because we have all the plasma walking around in our Canadian population. And this is just a couple of the vendors that we're working with. And what drives me insane is that during the Second World War, at a combination between Connaught Laboratories, the University of Toronto, and the Canadian Red Cross, we produced 430,000 units of dry plasma at the Spadina Crescent building during the Second World War. And we can't do it now. We just can't do it for regulatory reasons and not enough funding, other priorities. And when this is the product that everybody's going to be screaming for, if things go sour for us, almost 500,000 units. And the guy that led the program was Charles Best of Banting and Best, and so he was able to get that done. And so this was valuable for the Allied war effort, including in Normandy, and also for RCAF, RAF, burns and things like that. So this is about my sort of personality, I guess. But I was able to find a bottle of this dried stuff in a museum. It took me 3 years to find this bottle. And I was able to, with my help of my postdoc, we were able to reconstitute it and then actually analyze it, and actually still had activity in this 80-year-old dry plasma. So we were able to show 80 years, we did find that actually it had, we did some testing, viral testing on it. It did have hepatitis B in it, which was the reason why it was withdrawn in the 1950s, because they didn't have that testing, advanced testing there. But still, we were able to show that they could do this in the 1940s and 50s. And so I kind of felt like the Indiana Jones of plasma scientists. We're going through museums looking for old plasma and doing analysis on it. And my point is like, it was more about publicity stunt than anything. It's like, they could do it 80 years ago. What's the problem? Really. So just to sum up is, the next war is not going to be like Afghanistan. It was going to be a very different strategic and tactical environment. But human tissue and response to injury is going to be the same. That's not going to change. We have to realize there's going to be a lot of death and suffering, and we have to realize we're not going to be ready. And we're way down on that curve, and even to remain where we're at is going to take tremendous effort, or else we're going to keep falling. That, as we talk now, our capabilities are decreasing, despite our best efforts and all the great people working together, and even at the higher leadership levels. But this takes national level coordination until we get support of saying, we're reopening hospitals, we're making military beds, we're building capacity in the civilian system to manage all this. Because I can tell you, we can do the best deployed care, pre-hospital care, medical care over there, but if all the Canadian hospitals are blocked and we can't evacuate patients from our Stratovac hubs and MTFs, we're going to be filling those graves and putting those little white crosses up. So I would say the Ukrainians, with their valiant efforts, have bought us time, and they bought it in blood for us, but that time is starting to run out. The clock is ticking for us. And what have we done to prepare ourselves for something like this? And remember, this is going to be somebody's kid and daughter that's going to be saying, and they're going to be writing the epitaph on their tombstone, one day we'll understand. So that bill is coming due. So I'll just sum up there with this slide.
Time for questions.
Yeah.
Constance, did you want to just moderate, or I can as well, whichever.
Yeah, for sure. Are there any Eric?
Andrew, that was a marvelous presentation. I had never met the Walker dip before, but it strikes me that it is an exact parallel on a micro scale of what goes on with military preparedness at a macro scale. And Jack Granatstein and I have batted this around a few times, but we will not, in Canada, we will not take a war seriously until we have lost 2 battalions.
Yep.
I mean wiped out. Hong Kong and Dieppe in...
Yeah, I agree with that. That's the example I would use. And I think, I was talking to some research scientists that are focused on cold weather, I remember 10 years ago, we had this plan, my mentor and me, we were going to do, combat casualty care in the Arctic. We're going to look at this problem. And we were told we're never going to fight in the Arctic or cold weather. We're not going to fund that. It's not going to happen. And it's like, it's never happened before, we're not gonna fund it. And, but you go back, you go to the, Kiska with Operation Cottage when the Aleutian Islands with the Americans, is a lot of the casualties were due for environmental injuries, including entrenchments, was the major cause for medical evacuation from Kiska. We don't know our history, we forget the lessons, and the cycle repeats itself.
World War II is dead to living memory. There's nobody left that remembers World War II well enough to make policy from it.
Well, I think it's, and I think it's what frustrates a lot of people is the scale of it, because, when you talk to, healthcare leadership, it's like, the scale of the pandemic was enormous.
Mm-hmm.
And that's with everybody on deck. What if we had to send half of the staff away and we had to bring people back from retirement? I don't know, like for them, their eyes just glaze over. Like, well, we're just not going to talk. We're going to hope that never happens. It's not going to happen.
But if you go back to World War II examples and that losing 2 battalions, we lost a battalion in 41, we lost a battalion or more in 42.
Yep.
We'll lose them in the first 2 days of the war this time, in Latvia or Finland.
That's not unreasonable.
Mm-hmm.
It's, the origin, I agree with you, Eric, that this is, and I'm just talking on the medical side here, but again, what I'd say is like, unless the whole society is behind this thing, like us deploying medical treatment facilities, it's not gonna make any difference. Like, if we can't evacuate them, can't get them out of there, the patients are gonna keep coming and then people just die. And, the Canadian hospitals are like, nope, we're full, we can't take any burn patient. Well, do you know how many burn beds that there are in the province right now for burns? In the province of Ontario, 15. That's it. For specialized burn court, that's it. And you see the casualties coming out of the Ukraine, there are a lot of burns from armored vehicles, especially earlier on. And like, what is our capacity to do specialized burn care? It's pretty low. How many burn surgeons do we have in the military? None. Zero, yeah.
Andrew, how many trauma surgeons are in the forces now? It's like 8 or 10.
Yeah,
During Afghanistan.
like our total number we're supposed to have is 11, but I think of trauma trained people, we're probably around 6-ish right now. Yeah, probably around 6, but that would be, we couldn't really do much with 6 surgeons. We have to face it, because it's not just like we're sending a surgical team to Afghanistan and rotating people out. Like, we need a 60 to 100. And then we'd have to cope with losses. Like, we would lose surgical teams that they were targeted, and and we would have losses. And Ukrainian surgical teams, they set up an elegant system that, this is according to General Osashenko, is first of all, the forward surgical teams, they would just be stuck there months and months and months and months, and they're just getting burned out. And so they would just do whatever it took to get through the day with no really care of what the outcome was. And so what they started to do is like, okay, you're going to spend so many months at the front line on the forward surgical team, then you're going to rotate back to the rear, and then you're going to get experience on what's happening. You see the outcomes of what's happening, and also give the guys at the rear, the base hospitals, or the roll 3s or whatever you want to call it, or roll 4s, and rotate them through so everybody's got the experience. But there is no relief. There's not shifts. You're just there, and you do what you can. So there is no relief. And this is like over 600 days of doing combat surgery. 600 days. What is the we talk about moral injury and things like this, but when you have to do it, you have to do it. But you're going to lose people for fatigue and burnout, but to lose a surgeon or a very skilled nursing asset, that takes a lot of time and effort to replace that. So how do you give them and so I think these are serious challenges that you know, I think probably Eric's right, until we met with a serious reality that not much is going to change. But I think there'll be, if it ever comes to pass, and this is just me talking, there'll be some very difficult discussions about healthcare in the country. Who's a candidate for ICU? Because in the pandemic, we nearly got there for triaging for ICU, nearly got there. And I remember when the discomfort of physicians when we were starting issuing guidance from the ministry about how to triage for ICU beds. Who's a candidate, who's not, what ages, what conditions should not be admitted, who to prioritize. Like, people were very uncomfortable without those discussions. And this hopefully never comes to pass, but those would be, again, at least we've had one rehearsal for this, but it would be very difficult discussions.
I wanted to welcome any other questions from the floor.
Yeah, maybe just a last one. I mean, we can always discuss over drinks upstairs, but you talked about the way that industry is not prepared. The various supply chains are also not prepared for larger scale military action. And I think that has at least been mentioned. Canada has a representative at NATO headquarters. One of the Assistant Deputy Secretary Generals, Wendy Gilmore, is in charge of trying to put industry on a war footing. Are there any discussions like that from the medical side? Obviously, you've mentioned some of the agreements as far as blood supply, et cetera, are concerned. But is it more of a being brought to the political level so that there is a bit of an alarm raised?
Well, I think to your point is, I'm a military guy and I'm a lieutenant colonel, so a lot of these meetings I'm just sitting in the back benches, and that. But I did have to go and present to the Joint Health Group, which is the civilian representations of NATO's civilian health, representatives, and present these problems. And I think there is an awareness that how especially blood products would be shared and rationed and things like that, and also the supply chain vulnerabilities of all these things, because there's very few companies making blood bags like in the Western Hemisphere. It's all made in Indo-Pacific. Like, if there was something that happened at the same time, would we cut off I know some guys that are doing research, like, well, maybe we can use Coke bottles. And I'm like, well, they're doing research, like, maybe we'd have to do that. Like, I don't know, or milk bottles again, and that's what they did in the Second World War. They sometimes use milk bottles to, they sterilize milk bottles, they use blood, put citrate in and do it. Still blood. It's not magic, but it's.
So Andrew,
yes.
That's what we did when I started nursing back in the 1800s. I'm not joking.
No, it's glass
We
bottles.
had glass bottles, and we had 2-liter size bottles that we had to, and I was half the size I am now, hang up, and you saved everything, and you reformatted everything. But we're depending, which we've become very bad at doing, cheap and cheerful. I'll just leave those 2 CHs there. But that's what we did. And everything got reutilized. We used to sharpen the ends of needles so that they could be sharp, so it didn't hurt the person. These are the facts of history that we need to know and understand and appreciate how fortunate we are, but how careless we become. And I would say careless, not like children who are carefree, but we become careless. And we become self-indulgent. And I think it's really important because I've done street health nursing, I've been under the bridges, and we have people who are having peripheral vascular disease or trench foot right now in this city who don't need to. So these are really important aspects, and we need to, I would say, mobilize on a social community level and realize that if we don't recognize the importance of every single person in their way, who's going to recognize our importance?
Well, and with that,
But there's just one more.
Please go ahead.
there's a company called Calian that has had
Yep.
a long-term contract providing some health services to the Canadian Armed Forces.
Mhm.
Could you clarify for us the role they have vis-a-vis the staff of CF or Canadian Armed Forces?
I'm one of the connections. So I'm probably not one of the best informed people to talk about that, but they do provide a lot of services for in-garrison care and other services that are based in Canada. But I imagine, like, this is just me talking, in the event of any conflagration, that there'd be a lot of contracts sent out to organizations to provide things okay, well, maybe something like Calian, okay, maybe you're going to look after POWs in Canada. Who knows? I don't know. This is just me speculating, but there would probably be a lot of contracts being issued for this type of stuff that that the military doesn't have the initial resources to meet.
Well, with that, Colonel, thank you so much. An absolute pleasure to have you here.